I have just started the recording for the committee and for the audience to be aware. This meeting is recorded. We do have a quorum. We're waiting on one more committee member. So if my team or the OHA will help me monitor when, if and when that member arrives, we can make them a co-host as well. But welcome to the August P&T committee meeting / DUR board. One final time to announce for those in attendance, if you're able to add your affiliation, if you haven't done so already, either if you work for one of the CCOs or industry, it'll help us with the minutes. If you're unable, if you want to message one of the Sarahs, they can help take care of that for you. One topic for the 1 point of for the committee is we're going to attempt to do a roll call vote when we're taking action on items that are making recommendations to the OHA today. So I'm going to go write down my list, ask you to, sorry, one more member joining. I guess I don't want to repeat this, so bear with me. And we do now have 7 committee members, so a quorum plus 1. Mark, welcome. Thank you for joining us today.
Sorry for the delay.
No worries. We were just getting started loud and clear. I was just briefing the committee that we're going to attempt to do a roll call vote on items for which the committee is making recommendations to the OHA. So as we come up for a vote, please make sure and unmute yourselves, and I will go down my list and ask you to say yay, nay, or abstain. And so with that, we're going to go through roll call and introductions. Dr. DiMartino wasn't able to join us today, so Kat, we'll turn it over to you. Kat, are you able to unmute? I see you there still. Stacy, go ahead and take it away.
All right. I am Stacy Ramirez. I'm faculty at OSU College of Pharmacy and a clinical pharmacist and the director of pharmacy for the community health centers of Benton and Lynn counties.
Great. Thank you. Kat? I see you've unmuted. Tim?
Yeah, this is Tim Langford. I'm the pharmacy director with the Klamath Tribes in Chillicothe, Oregon.
Welcome. Karen wasn't able to join us today, nor was Robin. Bill?
I'm Bill Origer, family physician, faculty on the Samaritan Family Medicine residency program in Corvallis.
Welcome. Mark?
I'm Mark Helm, just a pediatrician from Salem, Oregon.
Just as pediatrician, right? Thank you. Welcome. Russ?
Hey, I'm Russ Hoffman. I'm a psychiatric nurse practitioner at Salem Health here in Salem.
Welcome. And Eddie?
Good afternoon. Eddie Saito, associate professor with Pacific University School of Pharmacy and clinical pharmacist with Virginia Garcia Memorial Health Center.
And again, welcome. Kat, I'm going to try one more time. I see you on the panel, but we are having audio difficulties. Are you able to unmute and introduce? I see the unmute.
How about now? Can you hear me?
Now we got you. Yes.
Okay. All right. I'll be on my computer in 3 minutes.
Awesome. Well, we won't have votes before then, but are you able to introduce yourself?
Sure. This is Kat Livingston. I'm the medical director of health chair and a practicing family physician, which is why I was late for this meeting, but I will be on the computer shortly.
No, I really appreciate it. And before we switch this screen, just want to point out at the bottom of the page a vacancy. We are statutorily required to have 5 physicians to be part of the P&T committee, and we have a vacancy. So if any of the committee members or any of the audience know of a MD or DO actively practicing in Oregon that might be interested in this important volunteer work, please have them get in touch with me or Trevor, be able to discuss the responsibilities, the requirements for the position, and to see if they would be willing to join us in this really important venture. So with that, we'll go over to the staff. I don't know if I saw Jennifer join us today. My name is Roger Citron. I'm the director of the Drug Use Research and Management Program.
I'm Trevor Douglas. I am the Director of Pharmacy for OHA.
I'm Dave Engen, OSU clinical pharmacist with the Derm team.
I'm Sarah Fletcher. I'm one of the P&T co-coordinators for the Derm team.
I'm Andrew Gibler. I'm the clinical pharmacy manager for OHA.
I'm Kyle Hamilton. I'm the pharmacy drug coordinator here at OHA.
I'm Megan Herring, clinical pharmacist and faculty with Derm and the College of Pharmacy.
Good afternoon. I'm Deanna Moretz. I'm a clinical pharmacist with the Derm team.
And I didn't see Amanda join us, so we'll go over to you, Kathy.
Great. I'm Kathy Santana, and I'm a clinical pharmacist with the Derm team as well.
And my name is Sarah Servid. I work with Sarah Fletcher doing P&T clinical co-coordinator with the Derm group.
I'm Lance Starkweather. I'm the pharmacy manager for Gainwell Technologies.
Dee Weston, pharmacy program policy advisor with OHA.
Hello, I'm Brandon Wells, pharmacy program analyst with OHA.
Welcome, everybody. As you can see, there's a pretty big team behind this to take care of and roll these meetings out. Next topic is the roll call, or excuse me, is the approval of the agenda. We've got no changes at this point that are recommended, so we'll stick with what's in front of the committee. So at this point, we also have the conflict of interest declaration. All of the staff and all the P&T committee members are required to have a conflict of interest declaration on file with the OHA, with an expectation that if anything changes during the course of their appointment to the committee, or for staff for that matter, or their spouses, that's reported to the OHA. We also require conflict of interest declarations from anybody wishing to provide public comment. So we have a few people today that have submitted those, and we'll make that a disclosure to the committee when we call on them. But with that, we'll ask if any of the committee members need to disclose any new conflicts of interest that should be made aware to the committee or the OHA. Excellent. Hearing none, we'll move on to the approval of the minutes. I sent out the minutes from the previous meeting held in June, so the committee could review those in advance. If you're following along on the packet, so the packet of materials has been posted to our website where you saw the meeting information to join us today. But the minutes will be found on page 3 of that packet. Any edits needed from the committee for those in attendance previously? And if not, we'd need a motion to approve.
Motion to approve.
Second.
Thank you, Kat. Thank you, Bill. And with that, I'm going to attempt my first roll call vote. So Stacy?
Aye.
Approve. Bill?
Aye.
Tim?
I suppose I should abstain since I wasn't there.
Okay. Eddie?
Abstain. I was also
Kat?
not.
You bet. Appreciate it. I don't know if we have you between phone and computer, Kat. Russ?
Aye.
Okay, thank you.
Aye.
Thank you. Mark?
Aye.
Appreciate it. Minutes are approved. With that, we'll turn it over to Andrew Gibler for the department update.
Yeah, well, once again, I want to thank the committee members for your time and your commitment to the state and to our Medicaid patients. We appreciate it very, very much. The only real update I want to share today is that we can confirm that the director of the Division of Health Policy and Analytics, Jeremy Vandehey, will be leaving at the end of September. So we'll likely have an interim director named by the middle of September. So we just want to thank Jeremy for his leadership and wish him the best in his new role at Pacific Source. And with that, I'll give it back to you, Roger.
Thank you, Andrew. Any questions from the committee for the department? All right. Hearing none, we'll move through the consent agenda. We have posted our CMS annual report on the website so that could be reviewed. That's just a recap of the previous work, the fiscal year that's reported to CMS, and reflects much of the work that you do and that informs the work that we do through the DUR process. We also included updates to our review standards and pharmacy and therapeutics operating procedures and quarterly reports. No one signed up for public comment. So if no one wishes to discuss any of those topics, we just need a motion to approve the consent agenda topics.
Move to approve, Origer.
Second.
Thank you, Bill. Thank you, Eddie. Again, I think since we have a motion and a second, I probably don't need to call on those people a second time. So I'm going to refine my skills as we go through this. So Stacy.
Aye.
Tim.
Aye.
Kat. Russ.
Aye.
Mark.
Aye.
Thank you. And I guess a person could move to approve and then not vote against it. So I probably should say Bill. And Eddie.
Aye.
All right.
Aye.
Great. Thank you. Kat, I will attempt once again. It looks like you might have made it to your computer. We'll give you the power of being a co-host, so you should be able to unmute.
Aha, I have the power now.
Woohoo!
Thanks.
Excellent. All right, thank you. As I mentioned, the P&T committee does serve as the DUR board for Oregon, and this is a DUR focused activity or meeting. So with that, a standing reports will be our prospective report, page 39 in the packet, and we'll turn it over to Lance Starkweather.
Thank you, Roger. I'll wait for Sarah to pop that up. All righty, so the prospective drug utilization review evaluates a patient's planned therapy before a medication is dispensed. This page shows a high-level summary of the types of DUR alerts. Most of these alerts are informational where the claim is set to pay. There are 2 alert types that are set to deny the claim. These are highlighted in yellow. The system will allow the pharmacist to override the alerts using the NCPDP drug use evaluation code, including reason for service, professional service, and resolution. For the early refill, this is where we have prescriptions that were previously filled for 30-day supply, but now is being filled after 20 days. This constitutes the most significant number of alerts for the quarter. Over 122,000 were received, of which 16,000 were overridden. This equates to a 13.5% override for the quarter, which is actually lower than the previous quarters. Typically, we see the percent overrides for the early refill ranging from 16 to 20%. The pregnancy drug interaction is the other one that's set to denied, and this is triggered when a teratogenic medication is being billed for a patient who recently had a pregnancy history. These alerts are often false positive, and typically a pharmacist will override many of these alerts. So for the second quarter, we have 34 pregnancy drug interaction, of which 31 were overridden. Next page, please. So this page shows the top drug enforced in the early refill alerts. It's broken down by the different type of therapeutic class based on the number of alerts received. The class with the highest number of alerts for the SSRI antidepressant, sertraline, fluoxetine, escitalopram, and citalopram. Over 20,000 alerts were received for this class, and 3,000 were overridden. This averages to a 8% override for the quarter. The next group with the highest number of alerts are the non-SSRI antidepressants. These include the bupropion, trazodone, duloxetine, and mirtazapine. Overall, we receive similar numbers of alerts as the SSRIs, but the percent of overrides averages a little higher. It's at 8.9%. If you scroll down a little bit, we have the Next group is the antipsychotic. This class represents the highest percent of early refill overrides compared to the other previous one. These include the second generation antipsychotics, quetiapine, olanzapine, risperidone, and aripiprazole. Over 12,000 alerts were received for this class, and the average percent of overrides was 11.2%. Next, we have the group I've listed is the anxiolytic. Buspirone has the most significant number of DUR alerts for this group. While the benzodiazepine doesn't have many alerts, I've included them here. This allows us to monitor if patient or provider outreach education is needed in case of abuse or misuse. So far, based on the low percent of overrides, it doesn't look like it's warranted. And then finally, it's just a list of miscellaneous medications that have a high number of override alerts that didn't fall into the other categories. And then lastly, I've also included Suboxone for the medication-assisted treatment for substance use disorder. Next page, please. So, thank you, Sarah. This page just shows a breakdown of the early refill reason code by month. For the quarter, we have over 11,000 early refill alerts that were overridden, of which 65% was due to submission clarification code of 7, which indicates that it's medically necessary. Followed by the next highest number of overrides due to a change in therapy. We also have about 5% of the overrides are due to a vacation supply or loss of medication. Next slide, please. Lastly, this is just a page that shows the cost savings report from the prospective DURs. So for April, we had 8 different alert types and 345 prescriptions that were not dispensed as a result. So that's a savings of over $73,000. For May, we had 5 different alert types. 79 prescriptions were not dispensed, which total over $17,000 in cost savings. And then for June, we had 4 different alerts and 75 prescriptions that were not dispensed, totaling over $17,000 in cost savings. So overall for the quarter, it's $109,000 in cost savings to the state. Any questions?
Hey, Leanne, it's Stacy. I have a question. Why did the types of alerts change from month to month?
It just depends on what is showing in the patient profile. So these are depending on the medication that is being dispensed and then the patient profile as well.
Okay, thank you.
I have sort of a similar question, I guess. This is Mark Helm. Like in April, there's a lot of early refills that is attributing a cost savings of $56,000, which is the bulk of the savings is reported for that month and actually for the whole quarter. The question I have is like, so if there were 245 early refills that were not dispensed, were those medications eventually dispensed? And if so, is it really a savings?
So these are captured if the prescriptions are not dispensed at all. So it would be a savings to the state because it wasn't dispensed.
But over what duration is, I guess what I'm saying is like they were not dispensed when they were originally submitted, but were they dispensed in a timely manner later?
I believe the system has set it up to be a week if it's not dispensed within the week, but I don't know for sure if that is correct. It is a longer duration. It's not like the next day that they get it and it's showing that.
So that's a good question, Mark. And I'm curious too. So if the early refill hits, a pharmacy can, as you previously were describing, override it with a DUR intervention code. And so if it's not overridden with that code and it's filled on schedule, then it might be counted as a savings?
Yeah.
Great, thank you.
That may not be accurate accounting because if they're trying to fill it early and they're 2 weeks early, but then they could fill it in 2 weeks, then it's not necessarily a savings. The other thing that I would worry about on that is, like, if we prevent someone from refilling a medication and say, oh, well, it's not refillable, and then the patient doesn't understand that they should come back and get it at another time, then they may just go off therapy. And so I just have some cautions around that, I think.
Yeah, and I think this is where pharmacists would provide the education. And they also call into the pharmacy call center if they need an override, and we can walk them through how to do that.
No, I'm not worried about the pharmacist's misunderstanding or the communication between the state and the pharmacist. What I'm worried about is the communication with the pharmacy tech who says your prescription isn't able to be refilled because of, we can't fill it, it's not covered. And the patient walks away believing that they can't get their medication and then goes off therapy.
Yeah, that is worth exploring. We'll look into that, Mark. So I appreciate your comment, because it means we either have an interruption of care, or perhaps we should be we should think about what we're counting as actual cost savings in this regard. So one or the other. And so if it is cost savings because they didn't fill, might be risking patients' care. So we'll look into that. But I appreciate those comments.
I appreciate it too. Thank you.
Mm-hmm.
Was that the last of your sheets, Lan?
That is it.
Awesome. Great job. Any final questions? All right. After prospective DUR, we have retrospective DUR. And we report this quarterly, kind of in conjunction with the quarterly reports that were part of the consent agenda. But draw your attention to page 43 in the packet of materials and turn it over to Dave Engen.
All right, thank you, Roger. Yeah, so now we're reviewing Q3 data. Once again, it's a snapshot in time regarding what we're doing in RetroDur space. And as you're familiar with this report, the numbers are cumulative, so they do increase over time. First, the one there, we recently added a change form initiative for aripiprazole tabs. And you can see the numbers there. We're still getting some uptick for the desvenlafaxine and venlafaxine switches as well. And the numbers are accordingly. And once again, those numbers will jump up over time as it accumulates. On the next page, 44, we have our dose consolidation. More of this is going on at point of sale now, so makes sense that we would eventually see less of this over time as it's handled at point of sale. We can go to page 45. This is our expert consult referrals for long-term antipsychotic use in children. Remember, after that initial identification, those that already have a PA or written for shorter term use, we typically put those aside, and those that rise to the top do get a referral. So there's fewer high risk, much fewer than you would see according to the initial number. So just a handful of those, and we do get referrals out there. And so you can see the numbers there that there are continuations, but we are alerting the specialists to that so they can reach out. On the next page, non-adherence prescriber messaging. When patients are, when they're 2 weeks late with their antipsychotic refills, notification goes out to the prescriber, and appears to be rolling along, and you can see about 40% end up with paid claim in the next 90 days. So That's more of a safety aspect. If you go to page 47, these are profile reviews. First 4 review categories, those are foster care kids, and we generate profiles for OHA, and it's passed along to DHS and then to Opal K if needed. We have a number of other high-risk profile review programs. You can look through there toward halfway through the page and toward the bottom. High-risk bipolar, mental health, opioids, etc. And prescribers will get an intervention letter when it's clinically warranted. So that's rolling along as well. If we go to the next page, these are our safety initiatives. It usually alerts providers and various prescribers to dangerous drug combos, or to let them know when a PA was denied and there was no follow-up therapy based on our claims data. So it looks like, in general, going through there, about 40% of the prescribers appear to be acting on the recommendations. So that's a good thing. And let's see, down toward the bottom, we even have oncology denials. There's very few of those, so not a whole lot to report there. And on that last page, we have the numbers for TCA follow-up notifications. And these are the number of patients that are denied a TCA without a new claim evident. And some end up with their therapy being switched, but we're kind of a safety net for those folks and get the message out to the providers. So once again, you'll see some of these numbers diminish over time. At least part of the reason is a change in prescriber practices. So as word gets out, the providers, they stop writing for certain of these agents. So typically there's less action in those areas and we don't have to message them. So the success of the program is kind of that sentinel effect over time. So once again, we want to thank the committee for adding great ideas and unique perspectives to this, and look forward to continue working, making progress retro-based. So any questions on those?
Yeah, this is Eddie. I have a quick question. Is retro DUR for psychiatric medications only done for the fee-for-service population or for the whole OHP Medicaid population, given the carve-out?
Yeah, that it is for all the medications that fee-for-service pays for. We end up doing the retro DUR for those, and it creates, as you know, just unique challenges as well with the communication. So we're careful how we message in that space, but yes, we do account for anything that fee-for-service for the carve-out medication. Hopefully I answered the question.
Did that address it, Eddie?
Yes, thank you.
You bet. Good question. Any other questions in regards to retro DUR? Any ideas that popped into anybody's mind, the things that we should look at? Always looking for opportunities to explore retro DUR. All right. Thank you, Dave. Education is also part of DUR activities, and one of the ways that we achieve that is through our newsletter. Kathy Santana is our editor, and I'll draw your attention to page 50 in the packet.
Thanks, Roger. So today I'll be recapping 2 newsletters that were published earlier this year. Second generation antipsychotic use in children and adolescents was a topic of the January newsletter. This is a great review of indications, appropriate use, and evidence to guide the role of second generation antipsychotics in this population. Updated 2021 treatment guidelines for sexually transmitted infections was the topic of the March newsletter, and starts on page 54. This is a detailed newsletter summarizing newly updated CDC recommendations on treatment, as well as prevention and care of people with chlamydia, gonorrhea, or syphilis. We really appreciate the authors who assist in providing this important provider education. And we also continue to send the newsletter drafts to the committee for feedback. And we always find your suggestions and comments very helpful. So thank you for that. The next newsletter, you might have seen, it was recently published on antimicrobial stewardship. So I encourage you to take a look at that. And then, yeah, similarly, I'd like to solicit the committee for any ideas regarding newsletter topics that you think might be of interest to providers. You can always email us with those as well. And then you can also sign up for the newsletter on the website to receive them electronically on our website, rather, to receive the newsletters.
This is Mark Helm. In terms of the newsletters, and maybe this is not the right space for it, but with the sort of shift from the list to EPSDT benefits coverage determinations, I think that there may be some confusion about what that means for medication coverage, and policies that relate around that. That seems a bit wonky, but I think that there are some differences, and I don't know if that's clearly understood by people, and I may be completely wrong.
Good question, Mark.
Yeah, that's.
Oh, go ahead, Kathy.
Go ahead, Rod. I was going to say that's a great question, and I'm not sure I'm the best to answer if this would be the best venue to clarify that or not.
Well, we are talking about how coverage for EPSDT in one of the criteria today. So I think your question is, might there be an opportunity to look at developing a newsletter that would explain how EPSDT overlays Medicaid coverage and informs what coverage is for members under 21? And
right, and I'm not sure if that's best to come from the drug program or if that comes somewhere else, but I think that it's useful and probably important for people to understand.
Yeah, certainly a provider matters, but there's folks on from the OHA, so we'll take that away and discuss it with them to see if this is the right venue. But education on that topic is being requested and would be of value. So appreciate those comments. Any other topics that come to people's mind? Burning issues that have come up in your practice, or? We're always open to those. So for consistency and transition, we'll keep it with Kathy Centena. We're going to transition now to preferred drug list new business. Again, draw your attention, if you're following along in the packet, to page 57, and it's the estrogen class update. So back to you, Kathy.
Great, thank you. So the purpose of this update is just to identify and evaluate new literature since the last review, which was done a little bit ago in 2017. We identified 2 systematic reviews, 2 guidelines, 2 new formulations, and 2 safety alerts since the last review. Just brief background on the estrogen products. The FDA approved uses for hormone therapy or for the treatment of menopausal symptoms and prevention of osteoporosis. However, it's also used off-label for gender dysphoria disorder and palliative care in breast cancer as well as prostate cancer. Long-term benefits and risk of hormone therapy have been mixed. Many of you probably remember the Women's Health Initiative, which found that hormone therapy did help prevent fractures and colon cancer, but there was a noted increased risk of cardiovascular events and breast cancer. There's also mixed evidence that has suggested a benefit in older women for the prevention of cardiovascular disease, osteoporosis, and cognitive decline. However, this has not been definitively shown in randomized controlled trials. And then the United States Preventative Service Task Force recommends against the use of hormone therapy for primary prevention for chronic conditions at this time. So the last review resulted in no changes in the estrogen derivatives preferred drug list. Our current policy does consist of PA criteria for those non-preferred products requiring a diagnosis, as well as for use in individuals that are less than 18 years of age. We do have a variety of oral products as well as patches and vaginal tablets that are preferred, and I'll refer you to Appendix 1 on page 67 to take a look at those. So looking at the systematic reviews, the first one done by Cochrane looked at long-term hormone replacement for those that were perimenopausal or postmenopausal, and they did find a benefit in the reduction of risk of fracture in estrogen alone as well as in combination treatment. as well as combination treatment and estradiol also did increase the risk of stroke, VTE, and gallbladder disease. The second systematic review from ARC looked at hormone therapy for primary prevention of chronic conditions in postmenopausal women. And they did show a reduced risk of diabetes and fractures with estrogen alone. And then in combination therapy, they found a decreased risk of colorectal cancers, diabetes, and fractures. However, there was that noted increased risk of harms with combination and individual products of estrogen, those being gallbladder disease, breast cancer, stroke, VTE, and urinary incontinence. So moving on to guidelines, high quality guideline done by NICE looked at menopause management with hormone therapy, and they found that it was effective and recommended for vasomotor symptoms, as well as urogenital atrophy, psychological symptoms, because those during menopause don't often respond to traditional antidepressant treatment, and also for altered sexual function. These were all recommendations based on low to moderate quality evidence. And they also noted the increased risk of VTE as well as stroke with hormone replacement therapy. Moving on to the next guideline, it's more of a specific guideline for those with systemic lupus erythematosus or I should say antiphospholipid syndrome. And it looked at hormone replacement in these women and found that estrogen products can be used for women with severe vasomotor post or menopausal symptoms that have SLE, as long as it's stable or inactive with a negative antiphospholipid panel. And there was no evidence of severe exacerbations with hormone therapy in those patients that have SLE and trials up to 24 months. And then women with antiphospholipid syndrome, we know that's more of a benefit risk situation, and so that they should be thoroughly evaluated for that against the risk of thrombosis and cardiovascular risk. Then moving on to new formulations, we have an oral product as well as a vaginal product. The first one is a combination oral product, estradiol and progesterone. And this is indicated for women with a uterus for the treatment of moderate to severe vasomotor symptoms due to menopause. A 12-week study did find a reduction in the weekly frequency of symptoms, and this was shown to be clinically significant with a reduction of 16.58 more symptoms compared to placebo. Anything more than 14, reduction more than 14 a week is considered clinically significant by the FDA. And then the severity of symptoms was also reduced by more than 0.57 more than placebo, which was almost clinically significant. Note, this product is interesting in that it is peanut free, so because it uses progestin instead of progesterone, or uses progesterone instead of progestin, which I thought was interesting. So that might be kind of a niche for it. But anyways, moving on to the next new product it's estradiol vaginal insert, brand name Efficacy. This was studied as a 4 microgram and 10 microgram formulation. It was approved for the treatment of moderate to severe dyspareunia, symptoms of vulvar and vaginal atrophy due to menopause. And it was shown to reduce these symptoms in these patients at 12 weeks more than placebo with both strengths. Now, as with all estrogen products, there is a black box warning for the risk of increased chance of stroke, DVT, PE, and myocardial infarction. And there's also evidence of increased risk of invasive breast cancer and probable increased risk of dementia in postmenopausal women 65 years of age and older. Next, we have a couple safety warnings for estradiol topical products. There has been an update to the black box warning for estradiol topicals that was there might be an increased risk of adverse cardiovascular events and dementia seen with the higher conjugated estrogen doses. And we have not fully studied the lower doses, so patients should be informed of this risk regardless. Additionally, for other estradiol products, there was evidence for increased risk of ovarian cancers with the use of hormone therapy. The exact risk is not known. This warning is based on retrospective and prospective epidemiological data that patients should be advised of this potential risk. And then as far as changes, no changes to PA criteria or the PDL are recommended at this time based on the clinical review. And I don't believe that we have any public comment. So at this time, I take questions, or maybe we do perhaps.
We do not have anybody that signed up for public comment, so I entertain questions from the committee.
Kat, I actually think that this might be a really good topic for a newsletter.
Oh, yeah, that's a great recommendation. Thank you.
Thanks for that, Kat. Any questions about the literature evaluation or any of the evidence that was presented? All right, we're going to take a vote, so unmute your lines. Again, we're not changing anything, recommending any changes, but still we'll confirm that you support our determination after looking at the information. So we're proposing to make no changes to the PDL based on the evaluation of the clinical evidence, and we will review an executive session. Do we have a motion to approve that recommendation?
Motion to approve.
Second.
Great, thank you. Stacy?
Aye.
Bill?
Aye.
Tim?
Aye.
Eddie?
Aye.
Kat?
Aye.
Russ?
Aye.
And Mark?
Aye.
Thank you. Motion passes unanimously. Thank you, Kathy. Moving on, we'll transition to page 73 in your packet for the PCSK9 modulator class update and new drug evaluation, and turn it over to Megan.
Thank you, Roger. Okay, so we will be, as Roger said, the PCSK9 modulators with a new medication in this class today. We last reviewed the PCSK9 inhibitors in August of 2021 as part of a larger class update for the non-statin dyslipidemia medications. But today we will only be focusing on the two PCSK9 inhibitors and the newer medication to evaluate any new evidence for the effectiveness and safety for the prevention of cardiovascular mortality and events in patients with clinical atherosclerotic cardiovascular disease or high CV risk. Next slide. So since we recently reviewed this class, there wasn't a lot of new data to present. There was one new systematic review that was identified, which evaluated the effects of alirocumab, which is a PCSK9 inhibitor, on cardiovascular events, CV, and all-cause mortality. There were a total of 13 studies identified with an overall low risk of bias. And consistent with findings from previous high-quality systematic reviews, there was high-quality evidence of a reduction in cardiovascular events with alirocumab compared to placebo of 10.9% compared to 13.4%. And there was no significant difference in cardiovascular mortality, 2.3% versus 2.7%. This review did find a reduction in all-cause mortality, however, with alirocumab compared to placebo, 1.6% versus 2.1%, and this is likely from non-cardiovascular mortality. Next slide. So the new medication in this class is Glycerone. This medication is a double-stranded small interfering RNA, which decreases hepatic synthesis of PCSK9, resulting in increased number of LDL receptors on the hepatocyte and ultimately increases LDL clearance from circulation. It was FDA approved, I think, in last December as adjunct to diet and maximally tolerated statin therapy for the treatment of adults with heterozygous familial hypercholesterolemia or clinical ASCVD who require additional lowering of LDL. Approval was based on 3 similarly designed randomized controlled trials that are included in this table. They were Orion 9, 10, and 11. They all evaluated subcutaneous injections of inclisiran 300 milligrams over 18 months. So it is given on day 1, 3 months later, and then every 6 months from there. It's a sub-Q injection, and compared it to placebo. You can see here that Orion 9 was in patients with heterozygous familial hypercholesterolemia who still had LDL greater than 100. And 10 and 11 were primarily patients with clinical ASCVD with LDL greater than 70 on background lipid lowering therapy with statin and/or ezetimibe. Orion 11 also included patients with ASCVD risk equivalent. However, the majority of patients in this trial had clinical ASCVD, so the population was very similar to Orion 10. The duration of the trials was 18 months, and the primary outcome in each trial was the % change in LDL from baseline. So you can see in the bottom row in this table that overall there was a significant difference in change in LDL from baseline in all 3 trials, of around a difference compared to placebo of close to 50% in each trial, just fairly comparable to the difference seen when you add a PCSK9 inhibitor onto statin therapy. Next slide. From the 3 primary randomized controlled trials, there were few discontinuations due to adverse events, about 5% in the inclisiran group and 7% in the placebo group. Inclisiran was generally well tolerated in the short term. The most common adverse event that occurred more frequently than placebo was injection site reactions. It occurred in 8.2% versus 1.8%. And you can see other adverse effects here that occurred more commonly than placebo. And long-term safety beyond 18 months remains unknown. Next slide. So main trial limitations, there was unclear selection bias, particularly in Orion 9 due to some minor differences in baseline characteristics. The primary outcome was not measured until month 17 to allow for steady state concentrations to be achieved, but this may increase the risk of unblinding if a patient did have an LDL drawn in the meantime. There was a high percentage of screened patients, about 30% in the trials, who did not meet randomization criteria, limiting overall generalizability. And there's limited data in non-white populations and insufficient evidence evaluating subgroups comparable to Medicaid recipients. Use of PCSK9 inhibitors because of the mechanism were excluded from all of these studies. So the safety and efficacy of inclisiran in addition to a PCSK9 inhibitor remains unknown. And lastly, as you saw from the trials, there's no data evaluating the effects of inclisiran on cardiovascular events or cardiovascular mortality. Next slide. So our recommendations are no changes to the PDL at this time. Evaluate comparative costs in executive session. And due to its unknown benefit on cardiovascular outcomes, maintain inclisiran as non-preferred on the PDL, modify the prior authorization criteria for the PCSK9 modulators to limit it to its indication and to those who have tried agents with evidence of cardiovascular risk reduction. So the PA criteria, I believe, begins on page 91. I didn't include the entire criteria on these slides, but you can see on the first page that we are recommending to change the PDL class from PCSK9 inhibitors to PCSK9 modulators to allow inclusion of inclisiran in the class. And then in the first criteria, we are not recommending any changes. We are still requiring patients have very high ASCVD risk with LDL of greater than 70 on maximally tolerated statin and ezetimibe therapy consistent with current clinical guidelines. And then when you get to number 9, we are recommending adding criteria for inclisiran requiring a trial of a PCSK9 inhibitor since they do have evidence of cardiovascular risk reduction, and also ensuring that the patient is not receiving both agents concurrently. Next slide. And then there were no changes recommended to the renewal criteria. Just a reminder that there is renewal criteria looking at evidence of LDL reduction and adherence to PCSK9 modulator therapy. And
Thank you, Megan.
Yep.
Questions for Megan? And we do have
yeah,
public.
Actually, hold on.
Oh, go ahead, Mark.
I do have a question. Looking at the numbers for the inclisiran, you know, the number of events that were expected or found, and the statistical significance, and then the question always becomes, what's the clinical significance of that potential reduction? So I wondered if there's like anything in terms of like numbers needed to treat in order to be able to sort of figure out where you actually get to a benefit with the use of inclisiran.
Yeah, none of these trials were designed or powered to detect differences in cardiovascular events. So we don't have that data yet on like clinical outcomes.
And this is Eddie. I have a question. I guess more of an observation really, but in the it's not so common that we come across these patients in primary care practice, but occasionally we do, and we're often not able to initiate these medications, at least for patients with CCO payers, because the PA criteria restricts prescribing to cardiologists or lipid specialists. And I noticed that was not present in this particular PA criteria. But like I said, that's often a reason why we're not initiating these therapies in the primary care side.
Yeah, thanks for that comment. I think, we have done that in the past in PA criteria, and I think, Roger could speak to this too, but we have more frequently not been including that just to allow for, better access and equity for Medicaid recipients who do qualify for treatment.
No, appreciate the comments, Eddie. And again, yeah, our criteria is focused on the fee-for-service population. But again, the OHA is on the phone or the call and hearing your comments, so they can take that away for consideration. So appreciate that. As I mentioned, we do have public comment. We have a representative of Novartis, Phil Wedestad. I don't know how do you pronounce your name, if I did that correctly or if I butchered it.
That's okay,
Are you
Roger.
able to unmute your line?
Yes, can you hear me?
Hear you loud and clear. Let you introduce yourself, and then the floor is yours for 3 minutes.
Thank you. Good afternoon, everyone. My name is Phil Wedestad. I'm a medical science liaison with Novartis Pharmaceuticals. I want to first thank you all for your time and the opportunity to share information with you regarding Leqvio or inclisiran, a new drug approved by the FDA in December of last year as an adjunct to diet and maximally tolerated statin therapy for the treatment of adults with heterozygous familial hypercholesterolemia or clinical atherosclerotic cardiovascular disease who require additional lowering of LDL cholesterol or LDL-C. Novartis respectfully requests that Leqvio be added as preferred to the Oregon prescription drug list. Cardiovascular disease remains the leading cause of death in the US, with ASCVD being the main contributor to cardiovascular disease. And despite the availability of numerous lipid-lowering therapies, effective and sustained LDL-C reduction remains a challenge, with approximately 80% of patients with ASCVD unable to achieve guideline-recommended LDL-C goals on statins alone. So Leqvio, again, is a first-in-class small interfering RNA LDL cholesterol-lowering agent, which uses the body's natural process of RNA interference to prevent the production of PCSK9 protein, thereby resulting in increased clearance of LDL-C. The recommended dosage of Leqvio in combination with maximally tolerated statin therapy is 284 milligram, administered by a healthcare professional as a single subcutaneous injection, initially, again at 3 months, and then every 6 months. In phase 3 clinical trials, Leqvio resulted in an effective and sustained reduction in LDL-C of up to 52% compared to placebo at month 17 in the patients with heterozygous FH or clinical ASCVD and elevated LDL-C levels, despite receiving maximally tolerated statin therapy. And Leqvio was reported to be well tolerated with a safety profile comparable to placebo and with no dose adjustment necessary in patients with impaired renal or hepatic function. Adverse events that occurred in clinical trials in at least 3% of patients were injection site reactions, arthralgia, urinary tract infection, diarrhea, bronchitis, pain in extremity, and dyspnea. Leqvio has no known drug-drug interactions, has no contraindications, precautions, or warnings in the FDA-approved label. In summary, Leqvio delivers effective and sustained LDL-C reduction of up to 52%. And with twice yearly HCP administered dosing after the initial dosing and again at 3 months, uniquely positions Leqvio to circumvent the adherence challenges commonly seen with other lipid-lowering therapies. In closing, Novartis respectfully requests that Leqvio be covered with a PA to the FDA-approved label to ensure appropriate access for Oregon Medicaid patients. Thank you for the time.
Great. Thank you, Phil. Any questions for Phil? All right.
I actually, sorry, Roger.
No, please.
I always have a question. That's just kind of a given. I was waiting for Bill.
That's why I have a pause.
Yeah. So I wondered whether or not there was any data on inclisiran in terms of looking at inflammatory markers, for the patients who had received the treatment. I'm one of the people who's not entirely convinced that it's all about LDL-C, that it's more about inflammation. And so I wondered if there was any information that that Novartis could share with the committee about the impact on inflammatory marker.
Yeah, that's a great question. Appreciate the question. I don't have the data in front of me right now, but I do know that we do have data regarding some other markers, for example, triglycerides, LP(a), et cetera. And I'd be happy to follow up and share that with the committee after the meeting.
I remember Niaspan, and I was before I became a physician, I worked on Cerevastatin. So I'm less interested in lipid profiles and more interested in the outcomes of the disease.
Right. It's a great question.
Any other questions? All right. Thank you again, Phil.
Thank you.
So the recommendations are again back in front of the committee. In addition to this, I would add that the recommendation is to change the class to the modulators. No changes to the PDL based upon the literature at this time. And again, because of its unknown CV outcomes, we're going to maintain inclisiran as non-preferred as it was coded when it came to market. Do I have a motion to accept these?
So moved.
Second.
Thank you, Mark. Thanks, Eddie. All right. Fingers on your buttons. Stacy.
Aye.
Bill.
Aye.
Tim.
Aye.
Eddie.
Aye.
Kat.
Aye.
Russ.
Aye. Aye.
All right. Thank you. Motion passes unanimously. And again, we'll revisit this after exec session when we come back into open session. Next, we'll turn your attention to page 97 in the packet. We have the oral thyroid hormones, and turn it back over to Kathy Centena.
Great, thank you. So the purpose of this review is to create a class for the oral thyroid products based on high quality evidence from a recent literature search. And what was found was 3 systematic reviews and 2 high quality guidelines that are included in this update. Levothyroxine accounts for about 92% of the utilization of thyroid hormones, and thyroid or low thyroid or hyperthyroidism actually accounts for just a small percentage of OHA patients. So looking at the next slide, just to review a quick background, we have 3 major agents in this class. The first one, levothyroxine capsules, tablets in solution, liothyronine tablets, and thyroid or thyroid pork tablets. These are all used for the treatment of hypothyroidism and dosed to obtain the appropriate TSH level. The guidelines mostly recommend levothyroxine first line, or not mostly, they do all recommend levothyroxine first line, dosed at 1.6 micrograms per kilogram per day, and then a reduced dose for those that are elderly and those with heart disease. Liothyronine, which is the T3 formulation, is used in patients that remain symptomatic on levothyroxine supplementation, but is not used by a large percentage of patients. And similarly, thyroid pork or armor thyroid, also known as desiccated thyroid, is a mix of T3, T4, and it also is not used very commonly. A full list of the thyroid products are available in Appendix 1 on page 108 if you're interested. Looking then at this review, we found 2 systematic reviews and meta-analyses. The first one from Cochrane looked at the use of levothyroxine for benign thyroid nodules. Now, this is an issue because these nodules do cause pressure and symptoms, as well as cosmetic concerns in these patients. It was found that levothyroxine did reduce the nodule volume by 50% or more when compared to placebo. A second review looked at levothyroxine for clinical and subclinical hypothyroidism in pre-pregnancy and pregnancy. And they did find that people that were euthyroid, but they did have thyroid peroxidase antibodies, that thyroid supplementation during pregnancy was beneficial in reducing the risk of preterm birth compared to no treatment. And this was an ARR of 19% and a number needed to treat of 5. Then looking at the last systematic review, this was a high quality review looking at people with subclinical hypothyroidism and the effect on quality of life and thyroid related symptoms. And what they found is that treatment with thyroid replacement compared to placebo did not improve health related quality of life or hypothyroid symptoms. So the treatment of subclinical hyperthyroidism is not recommended by many guidelines based on a strong recommendation and high quality evidence. However, there are a few guidelines that do recommend treatment in this population as it may prevent progression to overt hypothyroidism. So there is that caveat. So then looking at our recommendations from high quality guidelines, NICE came out with assessment and management of thyroid disease. And as not surprisingly, they do recommend levothyroxine first line for all patient populations with primary hypothyroidism. Liothyronine is not routinely recommended because of that lack of evidence and is of benefit as well as long-term adverse reactions. And then natural thyroid products are also not recommended for the same reason. They do say that levothyroxine can be considered in patients with subclinical hypothyroidism if they meet the clinical criteria. And then our last guideline looks at thyroid hormone use in patients with subclinical hypothyroidism. And this guideline does not recommend the use of thyroid hormone in this population, again, because there was a lack of benefit shown compared to no treatment in those 65 years of age and older for the outcomes of general quality of life, thyroid related symptoms, fatigue, tiredness, depressive symptoms, and cognitive symptoms. So the recommendation for this class is to prefer at least one formulation of levothyroxine, liothyronine, and desiccated thyroid to be available for patients as preferred products, and then evaluate drug costs in executive session.
Thank you, Kathy.
Mm-hmm. Can I ask for a clarification on the recommendation?
Sure.
This is recommendation at least one formulation of levothyroxine, liothyronine, and desiccated thyroid be available. Are you saying one of the 3, or are you saying one of each?
Oh, sorry, that's a great question. One of each. Yeah, one of each of those products be available without a PA.
Comment, Origer?
Sure.
Sorry, I'll ignore my phone here. With the lack of evidence for T3 and desiccated thyroid, why would we want to prefer those?
Yeah, that's a great comment, and that was a consideration as well. The thought process there was for those few patients that would benefit. Again, there was very little utilization in these products, but we just thought that it would be appropriate to offer that, open up access to that. But you're right, there's not good evidence to support it. It's just that that again, in those few patients that providers do use it, and thought we would just, go ahead and allow that.
Well, our challenge is to, and our goal is to use evidence, and the evidence really doesn't support this. And this is nothing new or different. Levothyroxine's been available for many, many years, and there's a lot of mythology and a lot of interesting beliefs about thyroid hormone replacement, which are not held up by the evidence. But I'd say we should stick with the evidence and only have levothyroxine as preferred.
Yeah, we could definitely go that route.
We can entertain a motion in just a second, Bill. There's one question that came in from the chat from Tim. For subclinical, were there any studies specific to diabetic or pre-diabetes?
There were not. No, that's a great point. That's a good question.
Okay. Other questions for Kathy?
Aren't there specific harms that are associated in terms of premature, like accelerated osteoporosis from the T4 formulation?
Yes, if they're treated, all the guidelines do recommend strongly against not using thyroid products in euthyroid individuals because of those harms and cardiovascular risks as well. Is that your question? So yeah, they that is mentioned.
On the T3 and armor thyroid topic, has it just not been studied with enough power to actually have significance, or has there been studies showing no benefit?
Yeah, that's a great question. It just has not been studied. It's a really old product and there just are no studies. So
there's no drug company funding it, basically.
Right. But they're also, yeah, right.
But I think that with that particular product, there's also a question of dose standardization as well. That I don't think that you can maintain consistent dose standardization with the armor thyroid product. I may be wrong on that, but that's recall from the depths of the brain here.
Well, this is always a hot topic in a teaching program, and so I try and keep up on this. There is very little standardization of desiccated thyroid, and so its mix of T4 and T3 is highly variable, and that's part of the problem. It's hard to maintain. And when the deficiency is in levothyroxine, and human levothyroxine has been synthesized and it's cheap and it's widely available, so it seems not only lack of evidence but counterintuitive to use anything else.
Yeah, those are great points.
Other comments?
This is Eddie. I would just add, I appreciate the perspective that, there are patients on these already and providers that might be using these formulations. At our own institution, we had discussions around our internal formulary and with regards to these products, and what we saw an increase in prescribing for those other formulations after we stopped, essentially after we opened it up to all three, rather than excluding it to just the levothyroxine. So I wonder if, if that might also result in a similar increase, despite low utilization of those other products right now. So just another consideration.
Yeah, that's a good point. I mean, currently there's no restrictions on any of these products, but that is a good point.
Another practical basis, the vigor with which some patients believe in the efficacy of these things despite the evidence is very difficult for most physicians. And I think a lot of physicians would welcome us not covering it.
In the clinical practice guideline, it explicitly says desiccated thyroid is not recommended for the treatment of hypothyroidism grade D Bell 4. Can you go into more detail about their rationale for that?
Just lack of evidence, and that guideline's very evidence-based. And so the fact, and again, it hasn't been studied. So it was the melding, I guess, this recommendation came from, again, just, I guess it's not widely utilized as other formulations. So in the off chance that they would find a patient that doesn't respond symptomatically, that would be an option. But yes, because that guideline is all evidence-based, it does recommend against it. Because there just isn't it hasn't been well studied to the point that was made earlier, as far as there's no funding behind it. And to Bill's point, there's no standardized, or there's not great standardization as well.
There's always a question too, if you have a patient who you're not seeing the response that you'd expect if they were taking their levothyroxine, it's probably more likely that they're just simply not taking their levothyroxine, that they need some different formulation of it. And you can look at pharmacy dispensing records and you can see that people are not entirely adherent to their medication regimen. So I know I always come back to that, but it's is C. Everett Koop that said that medicines don't work in people who won't take them.
True. That's a great point.
Good discussion. Other comments or questions? So Bill, what I'm hearing you say is to reject the recommendation that was put in front of you, but you would, let me put words in your mouth, propose to move to designate at least one formulation of levothyroxine as preferred and review prices in executive session?
That is correct. Thank you.
I'll second that.
Fantastic. Get ready with your buzzers. Stacy.
Aye.
Bill.
Aye.
Tim.
Aye.
Eddie.
Aye.
Kat.
Aye.
Russ.
Aye.
And Mark.
Aye.
Fantastic. Amended motion passes unanimously, and we'll review an executive session and come out and have recommendations after the session. With that, we'll continue on to the oral beta blocker class update. Draw your attention to page 112 in the packet, and we'll turn it over to Deanna.
Thanks, Roger. We can go to the next slide, Sarah. Thank you. So the purpose of this class update was to review and evaluate recent evidence and guideline recommendations for beta blockers, which, as you know, are approved for a variety of cardiac indications, in addition to infantile hemangiomas, ascites, or for migraine prophylaxis. The last time we reviewed the beta blockers was in 2015. Since then, we've had 5 high-quality systematic reviews that have been published, specifically to assess the safety and efficacy of beta blockers in hypertension, heart failure, migraine prophylaxis, and infantile hemangiomas. And then we also have 7 guidelines that have been published since 2015. Next slide, please. Oh, I will point out, if you're interested in looking at the preferred list of beta blockers, that is on page 134 in the appendix. And there is a comparison of the pharmacodynamic and pharmacokinetic beta blocker indications on table 1 on page 116. In terms of the systematic reviews, we had 1 systematic review from the American College of Cardiology and American Heart Association, which basically we're looking at management of hypertension, and compared to beta blockers, thiazides were associated with the lowest risk of stroke, all-cause mortality, cardiovascular mortality, and cardiovascular events. No class of agents was better than the thiazides. When we look at the Cochrane review published in 2021, they were evaluating beta blocker efficacy after MI in patients without heart failure. And the thought is that the beta blockers probably reduce the risk of all-cause mortality and recurrent MI based on moderate certainty evidence in this population. Next slide, please. When Cochrane looked at pharmacologic options for managing heart failure in patients with preserved ejection fraction or HFpEF, we have low quality evidence that beta blockers may help prevent heart failure hospitalization and quality of life in patients with preserved left ventricular ejection fraction greater than 40%, but the evidence is uncertain in that specific population. When we look at evidence for beta blocker efficacy in preventing migraine and tension type headaches, we do have high quality evidence that shows that propranolol 160 to 240 milligrams once a day is effective in reducing migraine frequency compared to placebo. At 8 weeks, patients with migraine headaches had an average reduction of 1.5 headaches per month with propranolol compared to placebo. Next slide, please. Looking at beta blocker efficacy in the management of infantile hemangioma, which is from the Cochrane review in 2018, we had moderate quality evidence that showed that oral propranolol compared with placebo is probably beneficial in helping to clear the hemangioma and reduces the hemangioma volume more than placebo. Low quality evidence showed that the timolol eye drops that were also compared in that systematic review may reduce the redness more than placebo, but we didn't have a whole lot of safety data that was assessed. There's no evidence of a difference between the oral propranolol and the topical timolol in terms of reducing the hemangioma size. That was low quality evidence. And then it's difficult to compare adverse effects because there was limited data for that. Switching to guidelines on the next slide, please, Sarah. So the first guideline we have is from the International Society of Hypertension in terms of managing adult hypertension. Basically, beta blockers are considered to be used to manage hypertension when there's a specific indication for their use, such as heart failure, angina, post-MI, AFib, or in patients that are planning to become pregnant or are pregnant. That recommendation is supported by the 2020 American College of Obstetricians and Gynecologists, who recommend either oral labetalol or calcium channel blockers to use in pregnant patients. Next slide, please. The European Society of Cardiology came out with 2 guidelines, one in 2019 that looked at management of stable coronary artery disease. And I apologize, there's a typo. It should be non-dihydropyridine when we're talking about the specific calcium channel blockers or beta blockers. Those are both considered first-line treatment for angina or ischemia relief to control heart rate and symptoms in patients that have stable coronary artery disease. When we were looking at management of heart failure, a beta blocker is most certainly recommended for patients with stable heart failure with reduced ejection fraction or HFrEF to reduce the risk of heart failure, hospitalization, and death. And that's based on high quality evidence. In addition, beta blockers should be considered for short and long-term rate control in patients with heart failure and AFib. That's based on moderate quality evidence. Next slide. So we have a couple more, one more guideline about managing AFib from the Canadian Cardiovascular Society and the Canadian Heart Rhythm Society that suggests either beta blockers or non-dihydropyridine calcium channel blockers, i.e. diltiazem or verapamil, should be used as first-line agents for controlling rate control in AFib in patients that do not have significant ventricular dysfunction. That is, they have an ejection fraction greater than 40%. That's a strong recommendation with moderate, based on moderate quality evidence. Specific beta blockers, including bisoprolol, carvedilol, and metoprolol, are first-line agents for rate control in hemodynamically stable patients with AFib in an acute care setting in patients that have significant LV dysfunction. In other words, their ejection fraction is less than 40%. Then the British Society of Gastroenterology and British Association for the Study of Liver came out with guidance in 2021 that support the use of non-selective beta blockers, i.e. carvedilol, nadolol, or propranolol in patients with refractory ascites, unless alternative markers of circulatory failure, such as low blood pressure or impaired renal function, are present. Our last guideline has to do with management of infantile hemangioma from the American Academy of Pediatrics. They recommend using propranolol as a first-line agent for infantile hemangioma that requires systemic treatment. That's a strong recommendation based on high-quality evidence. They also have some guidance regarding dosing of propranolol between 2 and 3 milligrams per kilo, unless there's comorbidities or the patient has adverse effects. In other words, their sleep is disturbed or those adverse effects may require a lower dose. Before the use of beta blockers, using steroids was the treatment of choice for infantile hemangioma. So those are continued to be recommended if there's contraindications or inadequate response to oral propranolol. And then finally, the American Academy of Pediatrics did have some recommendations regarding topical timolol, that only be used for thin hemangiomas or superficial hemangiomas. Next slide, please. So we can skip, this is just a summary of the specific indications. Onto the next slide, there we go, there's our recommendations. So based on current evidence, the recommendation is to make acebutolol non-preferred. It's not in any of the guidelines as a preferred beta blocker. And then we should also make at least one extended release propranolol product preferred and one oral propranolol solution preferred on the PDL. And we will review costs in executive session. Any questions on the evidence that I went through rather quickly?
Deanna, I don't know. This is really just a point of information for me. Are we still making distinctions between metoprolol salts? You know,
yes, the succinate versus the
versus tartrate.
Versus the tartrate in terms of
heart failure.
Yes, great point. I kind of glossed over that and went over that.
Well, you know, I'm a pediatrician, so
I'm glad you brought that up.
I don't have a lot of kids in heart failure, thank God.
Yeah.
The other thing I would say too is that in terms of the recommendations for propranolol with infantile hemangioma, you know, there are areas where the hemangioma are considered to be at high risk versus at lower risk, and so not every hemangioma, not every child should be treated with systemic propranolol, but there are some reasonable guidelines for when you might do it. And then of course you should use the oral therapy whenever there's risk for disfiguration, you know, because it's on the tip of the nose or on one of the pinna of the ear location.
Okay, great. I included that in the background. I didn't want to go into a lot of depth because.
No, I didn't know. I mean, if we're gonna be covering the solution without any sort of barriers, then it's not really a problem. But there might be reasons to cover the timolol gel forming.
The eye drops.
Yeah, for you know, but it's a specific age group, so it's fairly easy to identify when you're dealing with them.
Well, and that was the other challenge because this was a review of the oral beta blockers.
Right.
When I was looking at the different uses for beta blockers, I encountered that, and we haven't looked at beta blockers since 2015, so there was a lot of evidence to sift through.
Good job, Deanna. Other questions for Deanna?
Oh, I did have one other question because I see that the recommendation is to have a liquid propranolol and an extended release propranolol.
The extended release is for the migraine prophylaxis.
I understand, but sometimes we use propranolol also for, and this may be an off-label use, but we use it for panic attack. And so I'm not sure that an extended release formulation is necessarily what you want if you're trying to use it PRN panic attack.
Right, and we already have some immediate release propranolol that is preferred.
That answers the question then. Thank you.
We do have 2 people that have signed up for public comment, but first make sure there's any other questions for Deanna. Okay, hearing none, we'll start out with Dr. Arlene Maya. She's representative of Pierre Fabre Group. I've made you a co-host. Are you able to unmute your line?
Yes, I am. Thank you very much, Roger. Good afternoon, everyone. Should I go ahead and start?
Yes, we can hear you loud and clear. The floor is yours.
Great. My name is Arlene Mejia, and I'm a medical advisor with Pierre Fabre, located in New Jersey. Thank you for the opportunity to speak to you about the importance of having emangel propranolol hydrochloride on the PDL. IH is the most common tumor of infancy, affecting approximately 4.5% of all infants born in the US. But as Dr. Helm said, only about 12% of these cases require systemic therapy. That's about 20,000 children in all of the US a year. And they could be potentially debilitating and associated with serious conditions that are life-threatening, functional impairing, like loss of vision and hearing, posing a risk of ulceration with bleeding and pain, or posing risk of permanent disfigurement. For these severe forms, systemic therapy is essential to initiate the involution process. Emangel is a specific pediatric oral solution of propranolol hydrochloride, which obtained FDA and EMA approval for its use in treating infants as young as 5 weeks with proliferating IH requiring systemic therapy. Emangel was developed in compliance with existing guidelines for pediatric drugs, which recommends less than 0.5% alcohol content in pediatric formulations. And Emangel is the only alcohol-free propranolol formulation developed specifically for infants. So we also have no sugar, and no paraben. Sugar has been associated with osmotic diarrhea, which can affect the overall difficulty of managing the baby for both the parent and the physician. We know that Emangel's efficacy is well established, and the AAP guidelines of IH management clearly state that it is the first-line therapy. Medication errors are a common occurrence in prescribers who use adult formulation of propranolol in infants. In a survey conducted by the University of St. Louis, 220 IH experts reported that dispensing and calculation errors are very common among physicians prescribing adult propranolol solution to treat infantile hemangioma. 30% of all physicians experienced the calculation error when prescribing the adult formulation, which was 3 times greater than calculation errors with Emangel. Physicians also regularly express the need for the pediatric formulation when dosing, especially for smaller infants. We respectfully request this committee to include Emangel on the PDL, or at minimum authorized for age and indication. Exposure to adult formulation increases adverse events, complications, and exposes infants to alcohol unnecessarily. We do not ask that propranolol solution be authorized for all patients, just for the right child. Thank you.
Thank you. Any questions for Dr. Maya? All right. We also have Dr. Allison Small. She's a physician from OHSU. So in these situations, the committee's more interested in your conflict of interest declaration. Dr. Small did indicate she's been asked to provide testimony by the manufacturer, and that she's also currently a primary investigator for a phase 2 clinical trial for Palvella Therapeutics. Dr. Small, are you able to unmute yourself?
Yes, can you hear me?
Can hear you loud and clear.
Okay, great. Hi, everyone. Thank you. This is Allison Small. I'm a board-certified pediatric dermatologist and the only dermatologist that serves both children's hospitals in Oregon, both Dornbecker and Randall Children's Hospitals. I'm also the director of the Oregon Health and Science University Hemangioma and Vascular Birthmarks Clinic. I appreciate the time to speak to you today on behalf of the children of Oregon. Infantile hemangiomas, as you have heard, can be large, life-threatening, disfiguring, functionally impairing, ulcerative, or associated with underlying medical conditions such as face and lumbar syndromes. Because of these complications, it's imperative that we treat these hemangiomas early and effectively. I have seen children with large, painful ulcerations that take months to heal, loss of vision, trouble breathing, inability to eat properly, and more due to these hemangiomas. Propranolol works quickly and is safe and effective for the treatment of hemangiomas, and Hymangiol specifically is the only FDA-approved treatment for infantile hemangiomas. Generic propranolol is not formulated for infants and increases the risk of reflux and spit up. It's also often not tolerated and can be challenging to get babies to take their medication. Because of this, some babies don't get their optimal dose, and this can lead to delays in appropriate therapy while awaiting approval of Hymangiol. I've had numerous patients immediately stop spitting up and show rapid improvement in their hemangiomas once they were changed to Hymangiol from generic propranolol. Hymangiol is specifically formulated for babies and helps prevent reflux issues to ensure babies are getting their complete dose. Additionally, all children should be able to access the FDA-approved treatment that does not have alcohol in the formulation. As the generic version of propranolol solution has more alcohol than recommended by AAP guidelines, it would be in the interest of the children of Oregon to have access to Hymangiol as the primary treatment for infantile hemangiomas when necessary. In my experience, treatment with Hymangiol is preferred, and I recommend that it be added to the preferred drug list. I also wanted to just add a comment as I heard timolol came up as well. I know this is more for systemic, but I do also believe that the timolol gel forming solution, 0.5% gel forming solution, should be added to the preferred drug list as well. We don't have any other alternatives at this point, and being able to have that gel solution really does help keep the medication on the